Hello, guys. Today we're going to be going over the cardiac arrest protocol. Near the end, we're going to talk about the COVID 19 specific changes. So, cardiac arrest for some of our new EMS providers, this can seem like a pretty intimidating call. But the important thing to remember here that even though we're using a lot of our skills, these calls are often very mechanically easy to perform. All the difficult things that we need to do have been made easier for us because we have the iGel for an airway, we have our CPR devices for the compressions, and we don't have to necessarily look for IV access because of the IOs. So all the difficult skills have been mitigated for us to be easier. So with that being said, there are some things that we could do to make these calls easier for us as well. Oftentimes when we encounter these patients, they may be in a difficult position where it's inconvenient to work in a rest. They may be in bed, they may be in a tight bathroom. So it's very important that we take the time, just a couple of seconds, to move them to a space or to make room, to make space for us to be able to effectively perform all these procedures in an efficient way. Because bottom line, if we don't take that time, we're gonna be kicking ourselves in the butt the whole code. So the first thing we're going to do for these calls is to determine if CPR is necessary. Do they in fact not have a pulse? Are they not breathing? If not, then we are going to do CPR unless it's contraindicated. So some of the things for contraindications are: do they have a DNR? Do they have a valid pulsed form? Are they a 000, or potentially is this a significant trauma? CPR is not going to be effective. So we have our 000 protocol, and some of the things in there are pretty obvious, like decapitation, transection of the body. Obvious these patients are going to be non-survivable. But some of the things in there that specifically apply to our full arrest protocols are rigor mortis and profound dependent lividity. So rigor mortis is the stiffening of the muscles after someone passes away. Onset is usually about 4 hours, I believe 4 to 6 hours. So it starts a little bit sooner in the smaller muscles, but that's not really noticeable. So if we have a patient that has rigor mortis, they've been down for at least 4 hours. So that's one. The other one is profound dependent lividity. And what this is the pooling of the blood by gravity. So whatever the lowest point on that body is, if they're laying in bed, it will be in their flanks and their back. The blood is pooling down. Onset for that is going to be 2 hours when it becomes noticeable. If you see any pooling of blood, that person is going to be non revivable. Fixed lividity is the same thing, but that blood has coagulated, and no matter where you move that patient, that blood is fixed there. Whereas this dependent lividity, if they move around, that blood's going to shift. So after assessing our patient, determine that CPR is indicated. The patient is not a DNR. They do not have a pulse form. So we're going to begin compressions. So we're going to move these patients to a clear spot where we can adequately perform all the skills that we need. And we're going to remove their life vest, which is a external defibrillator if they have it, and we're going to disconnect those life vest batteries. If they have a ventricular assist device, we are not going to disconnect those batteries. We're going to talk about ventricular assist device more in another protocol review this month. So once we begin our CPR, we're going to do this in 2-minute cycles, and we're going to switch out every 2 minutes, regardless if we feel like we can keep going or not. Sometimes we may not have the personnel and other things are getting performed, so you might have to extend your compressions by more than 2 minutes, but it's really important that we try to really stick to that 2-minute sticking point. Studies have been done by the AHA, and I'm sure other organizations, where they analyze the quality of chest compressions and how they decline over time. Consistently, the results show that after 2 minutes, compressions start to suffer. So we're going to use a pit crew approach or a team approach, however you want to call it. In my experience, we always have someone at the head that's doing airway. We have someone doing compressions, and we have our third person on the opposite side of the chest that is going to be switching out compressions. Our fourth person is at the feet. They're doing the IO and pushing the drugs. And then we have our fifth person that's usually rocking the clipboard. Sometimes we have the fortune of having a sixth with shift commander. There is one person that's free to help hand materials or supplies, whatever is needed. Okay, so We're doing our CPR, our manual chest compressions, and if we have the CPR device, which we hopefully will be getting the Zoll CPR devices soon with a grant. If not, we're getting at least one. We're going to place on our CPR machines, and they want us to keep this to 5 seconds or less. And that's definitely something that we're going to have to practice. And if no CPR device is available, which currently we don't have one, we're just going to continue with our standard CPR per AHA guidelines, whether it's an adult, child, or infant. So now that we have CPR in progress, we're going to begin with our apneic oxygenation for all patients 13 years and older unless contraindicated. So exceptions for some of these contraindications are going to be cardiac arrest caused by a hypoxic event, so an asthma patient, an anaphylaxis patient, or submersion patient. The idea behind apneic oxygenation is that most likely, especially for our older patients, that this is going to be cardiac in nature. So we need to get that heart going and that they have oxygen in their bloods, and we just need to begin circulating that. So for the apneic oxygenation, we're going to be placing a non-rebreather mask at 15 liters and then an end-tidal sensor under the non-rebreather mask, and we're going to initiate CPR. Now, as we are doing our compressions, what that is doing is it's creating pressure changes in the thoracic cavity. And as we release the chest from our compression, air is going to draw into the lungs. So we're providing that oxygen at a high flow rate that's going to be provided into the lungs, and that's going to be exchanged into the blood through the alveoli of the lungs, largely in part due to our compressions. So the reason why this is 13 and older, again, because the older our patients, the more likely the cause of the arrest is going to be cardiac in nature, whereas if we have our younger patients, that's typically more respiratory in nature. So that is our apneic oxygenation. Again, this is going to be for the first 6 minutes unless contraindicated. Now, by all means, if you can insert that airway without interrupting compressions, insert the airway and do your ventilations, through the airway with our end-tidal sensors and everything like that. We're also going to apply defib pads without interrupting compressions, and this is something that's easily done. It may be more difficult to do this if we have to do an anterior-posterior placement, especially if we're doing a rest on a peds patient. We can't really place them in the standard position. We do have CPR feedback devices, so we don't even need to stop compressions to necessarily read a rhythm. Now, if we can't read the rhythm through the see-through CPR, something that always worked for me is when you're changing compressors, you could take a look at that rhythm in that short pause there. If that pause is too quick that you really can't get your eyes on it and you really want to look at it, then you can just hit record prior to switching your compressor, and then while it's recording, you switch, you have your new compressor come on. Now you at least got a second strip that you can read. So that's another option for us if you don't like the see-through CPR. Okay, so now we're going to talk about timing our shocks. And this could be something that, is a little bit hard to assess in the field because we're going to start CPR right away and we're going to shock as soon as possible because it's electricity that saves our patients' lives. So we are going to shock immediately or as soon as possible if we know that the patient's downtime is less than 5 minutes, less than or equal to 5 minutes, or they're on course VFib or pulseless ventricular tachycardia, or their end-tidal CO2 is greater than 20. So basically, if any of these three criteria are present, we are going to defib them. All of these things indicate that their heart is in the electrical phase and it's ready to be converted. If they've been down for less than 5 minutes, most likely their end-tidal is still going to be relatively high because they have a lot of oxygen floating around in their blood. They're not going to stop perfusing right away, but they will stop perfusing pretty quickly. They're still going to have a lot of activity, a lot of electrolytes in their heart, so we're going to have this course, rhythm. That's why we have the course VFib or the pulseless ventricular tachycardia. So if they meet one or more of the criteria below, we're going to consider a need for delayed defibrillation. A delayed defibrillation is defined as 2 minutes with high quality CPR and ventilations. So we're going to do that for 2 minutes and or until their end-tidal is above 20. So we can be doing compressions for 1 minute, and if their end-tidal becomes above 20, then we're going to defib them. Now, a lot of this is just conjecture because if we're getting to our patient and we're deciding if we're going to delay or not delay defibrillation, most likely we're right in the beginning of our call. So we might not even have end tidal on them at this point, and we might be doing CPR for 2 minutes before we're really ready, to decide if we're going to defib or not. There's a lot of things that could potentially be going on. So keep in mind that this may not even be a consideration by the time we get to it. So, but the things that are going to cause you to consider delayed defibrillation is going to be if we know they have a prolonged downtime of greater than 10 minutes. If they have very fine VFib, which is hard to distinguish from asystole, or if their end tidal is less than 20. Now that we talked about when to defibrillate, we're going to talk about how to defibrillate. For our adult patients or children greater than 50 kilograms, we're going to just go with our standard dosage. For the Zoles, that's 120 for our first shock, 150 joules for the second, and then 200 joules for every subsequent shock. For the child, this is a little bit more confusing because there's some conflicting information between the chart in the appendix and then how it reads here. But this is how I interpret it. I go by the chart in the appendix. For our defib doses, it says we start at 2 joules and then we move up to 4 joules. So for our 50 kilogram patient, our first shock is going to be 100 joules, and then our second shock is going to move up to 4 joules per kilogram, so that's going to be 200 joules, and we're not going to exceed that 200 joule limit. So now that we doing the shocks, if we have automated CPR devices, we're not going to pause our compressions. If we're doing manual compressions, we're going to pause our compressions, but for no less than 5 seconds. We're not going to look to see if the shock was successful. We're going to immediately resume doing our CPR. We're going to assess for ROSC through other means. Now down here it says we have equal but separate priorities that are performed simultaneously. So we have the advanced airway and vascular access. Now this can be a little bit confusing because just a little bit earlier in the protocol, it talked about how they want us to do apneic oxygenation. So we're not providing ventilations. We're not inserting an advanced airway for potentially up to the first 6 minutes. So in that case, vascular access is going to take priority over an advanced airway. Now, in actuality, we always get the IO right away. We're doing CPR, someone's doing compressions, someone's at the leg, they're doing the IO, and then someone's at the head and they're prepping the airway. So this is not something that we actually need to really involve ourselves in the weeds here because we get this stuff done very quick regardless. So the advanced airway, they want us for standard cardiac arrest without COVID. They want us to use the iGel. The iGel is great because anyone can insert the iGel regardless if they're an EMT or they're a paramedic. It's a super easy airway to place, and we do not need to interrupt compressions to insert the iGel. So even though the iGel is a super easy airway to insert, it does have its disadvantages. When we insert it, it basically molds to the patient's airway and creates a seal as it warms up. Now, if we're working a hypothermic arrest or the patient is just not that warm, they are dead, it might not mold effectively to really create a good seal. Also, these are based off of ideal body weight patients, and there's a decent range. A patient might be at the cusp of being good for a size 4 or good for a size 3, and we're just not going to have a good seal. So we tend to get a little bit of gastric ventilation with these iGels, and that's why they have that suction port that we insert, and we maintain suction with these iGels at all times because they do tend to ventilate a little bit of air into the stomach. So even though the iGel is placed, we're still going to confirm placement with 5-point auscultation. We're going to be listening to epigastric sounds. We're going to be listening to their lungs, make sure we got good air moving. We're going to secure that tube with a device that's provided with the iGel. We're going to place on the end tidal. We're going to monitor their capnography just as we would if it was a ET tube insertion. And we want to stabilize the head and the neck. So I know when we're in the field, we don't really do much to stabilize the head and the neck other than having someone deliver ventilations at the tube. Now that person obviously is going to be controlling the patient's head. They're not going to be moving their head back and forth. So the head and neck is relatively stable in the field when we're working our codes. Where this becomes an issue is if we decide that we're going to transport this patient and we're lifting them, we're getting them onto the stretcher and we're moving them in the back of the ambulance and then we're transferring them over. We want to, at minimum, place towel rolls to keep that head in a neutral alignment. So just keep that in mind, that stabilizing the head and the neck is a priority, especially if we're transporting the patient. So ideally, we have our airway in place, whether it be an i-gel or potentially an ET tube. We want to place our rescue pod, ideally, on our advanced airway. Now, we don't necessarily need a advanced airway to use a rescue pod because we could attach it directly to the bag valve mask, or we can attach it to the advanced airway. So what the rescue pod is, it's ITD. It stands for Impedance Threshold Device. So this is basically going to create a negative pressure in the chest when we release our compression. That's going to help draw blood into the thoracic cavity. So if you think about it, if you're just doing hands-only CPR and we got nothing else going, you're doing compressions. Every time you compress the chest, you're going to be pushing air out. That's going to be coming out of the patient's mouth. And then as you release pressure off the chest, now you're creating a vacuum that's going to draw air in. That's how we breathe naturally. So what this does is it prevents air from being drawn in when we release the compression. So that creates a slight vacuum in the chest that's going to draw the blood back into the chest, from the circulatory, which is going to increase blood flow. So that's the theory behind the rescue pod. So when we're using a rescue pod, we want to make sure, if we're using it in conjunction with an advanced airway, that we have our advanced airway in place, and we have our end tidal adapter on the advanced airway, and then we have the rescue pod on top of that. So that way our end tidal adapter is not getting blocked by that impedance threshold device, and we're getting a constant end tidal CO2 reading to assess our patient quality of our respirations and if we get ROSC. So after our airway's in place, we're going to ventilate the patient at 10 breaths per minute, and we can just look at the monitor and titrate that to 10 breaths per minute. This is like an asthma type of call. We're going to ventilate at 6 to 8 breaths per minute. Pediatrics, it's going to be 1 breath every 6 seconds with just enough volume to see chest rise and hear bilateral chest sound. And then for the vascular access, we want to keep that TKO. Keep this in mind, TKO. I don't know how many arrests that we go on, and we just flood these patients. We got that pressure infuser going, and before we know it, half the bag is given, almost, 700 milliliters of that bag is given, and now we just got fluid coming up the tube. That's not necessarily a heart failure patient. We flooded that patient with fluid. So keep that in mind. We don't need to be hyper aggressive with our fluids when we're doing, when we're working arrest, unless we suspect that they arrested because of a hypovolemic type of cause. Bear in mind, we're doing manual compressions, at least we have been for the past couple of years. We're not moving that much fluid. So if we're introducing a lot of fluid, it's going to begin to back up at some point in time. Now, word on the street, these Zoll auto pulses do a great job of moving fluid. In fact, they're contraindicated in traumatic arrest because they do too good of a job, and they would be busting through clots and all that kind of stuff. So maybe with our Zoll auto pulse, we're not going to run into so much of a problem of fluid overloading these patients, but it's definitely something to keep in mind. We just don't want to keep that thing, pressure infused and just blowing through that bag in a matter of minutes. That's not healthy for us when we're alive. We wouldn't necessarily do that to a living person. So why do we want to do it to a dead person in a compromised perfusion state where they're not moving fluid? That's my soapbox. Okay, finally, we're getting to the drugs. So epinephrine is going to be given for every cardiac arrest, and we're going to be giving that whole preload for our adult patients. If our arrest is due to anaphylaxis, then we're going to be referring to our anaphylactic SOP and our high-dose epinephrine, which is part of a different protocol. And we're going to do epinephrine every 5 minutes. Now, this is a change from previous protocols, where it's every 3 to 5 minutes. Now it's every 5 minutes. The great thing about epinephrine is when you give it, it increases the chance of return of spontaneous circulation. The bad thing about epinephrine is that when you give it, then those ROS patients have a higher chance of not making it to discharge. So it saves you, then it kills you. So for our peds, we are still giving epinephrine, but it's going to be 0.01 milligrams per kilogram, which works out for our preload syringes as 1 ml per kilogram. So if they're 9 kilograms, we're going to give almost that whole vial. We're going to give 9 mLs. So if they're essentially 21, 22 pounds or heavier, we're giving them the full preload syringe of epinephrine. Now, if they have a shockable rhythm, VFib or VTAC, without a pulse, we're going to be giving amiodarone, and we're also giving this every 5 minutes. So our first dose is going to be 300 milligrams. That's going to be 2 vials worth, 6 mLs. And then we're going to follow up with 150 milligrams 5 minutes later, which is going to be 1 vial's worth. For our peds, we're going to have to dose that out 5 milligrams per kilogram, followed by 2.5 milligrams per kilogram. They have persistent or refractory VFib, so we're giving a bunch of shots and just nothing's happening. We can't call it because they're not in asystole. So we could try a couple different things here. We can change the location of the pads to an anterior posterior position and re-defibrillate. Another thing to consider is dual sequential defibrillation at device-specific Joule settings. We tried this once in the field years ago when this first came out, and the guy was kind of hairy, and man, that hair was smoking. You could smell that burnt hair everywhere. Didn't work out for us, but this is something that's kind of hard to coordinate. We do have our AEDs in the engines, and we have our monitors. If you're doing a bunch of shocks and it's like, hey, what can we do? Hey, let's grab the AED and let's try dual sequential defibrillation. Something to consider at minimum when nothing else seems to be working. But if nothing else seems to be working, then what we need to consider are our H's and T's. Here are H's and T's. Instead of me droning on about this, I'm going to play a short video.
When managing a patient in cardiac arrest, in addition to CPR, defibrillation, and vasoactive medications, you should be reviewing the potentially reversible causes of their cardiac arrest and acting to correct these if they are suspected. These causes are easy to remember and could potentially be life-saving for the patient. We'll call these reversible causes the H's and T's. So let's talk about them in more detail. Hypovolemia is a common cause of cardiac arrest, which can occur as a result from excessive fluid or blood loss. This results in decreased amount of fluid volume in the circulatory system, leading to decreases in tissue and organ perfusion. Examples of this include excessive amounts of diarrhea and/or vomiting, bleeding from traumas, volume loss from severe burns, etc. After starting CPR, the most important intervention is obtaining some sort of circulatory access, whether it's an IV or an IO. Subsequently, a fluid bolus should be given if you suspect hypovolemia, and in traumatic causes, blood and blood products can be considered. Hypoxia is a lack of adequate oxygenation to your organs and tissues. Because your respiratory system is a major determinant of oxygenation, you should pay close attention to your patient's airway and breathing. Make sure your patient is protecting their airway and that it is patent. Make sure that they are breathing and have bilateral breath sounds during respirations. Oxygen saturation measured by a pulse oximeter can also help in determining a patient's oxygenation. If needed, oxygen may be administered to the patient, and if the patient is not protecting their airway or not breathing adequately, further interventions, such as BiPAP or endotracheal intubation, may be considered. Remember that acidosis can be either metabolic or respiratory. Obtaining a blood gas is a quick way to determine if a patient is acidotic. In general, a pH less than 7.35 is considered acidotic. If a patient's process is a respiratory acidosis, ensure that they have adequate ventilation. If the process is a metabolic acidosis, you may administer sodium bicarbonate. Potassium is an important electrolyte which plays a role in maintaining normal electrical conduction and contraction of the heart. If levels become too high or too low, a patient may go into cardiac arrest. There are many causes of hypo and hyperkalemia, but regardless, it must eventually be determined to definitively treat your patient. However, in the emergent setting, certain medications should be considered. Hypokalemia is defined by a potassium level of less than 3.5 milliequivalents per liter, but you will begin to see EKG changes at levels less than 2.7. So, in the setting of hypokalemia, on an EKG you may see flattened or inverted T waves and prominent U waves. You could even see a prolongation of the PR interval. If you suspect hypokalemia, giving potassium quickly is important. With hyperkalemia, it is defined by a potassium level of greater than 5.5 milliequivalents per liter. At these levels, you will begin to see the earliest signs of repolarization abnormalities, like peak T waves. At levels greater than 6.5, you will start to see flattening of the P waves and a widening of the QRS complex. You could treat this initially with calcium, which will stabilize the cardiac membrane and should be the first medication given in the immediate setting. Other medications such as insulin and glucose, sodium bicarb, and furosemide can be considered but take longer to work. And ultimately, these patients may require hemodialysis. Hypothermia is defined as a core temperature below 35 degrees Celsius. Now, a person should never be declared dead unless they're warm and dead. When the body's core temperature drops below 30 degrees Celsius, cardiac output is decreased, which can lead to cardiac arrest. The body may not respond to CPR and defibrillation during these hypothermic states, so rewarming should be started. Things like passive external rewarming with warm blankets or active internal rewarming with warm IV fluids. Attention pneumothorax occurs when there's air in the pleural space. With enough air in this space, a shift in the mediastinum can occur, which can compress the blood vessels leading back to the heart. As a result, preload is decreased, leading to a decrease in cardiac output, which can lead to cardiac arrest. Patients may have decreased breath sounds on the side of the pneumothorax, and there may be tracheal deviation away from the side of the pneumothorax. As a result, these patients can have difficulty in ventilation, and you may even see evidence of a pneumothorax on a bedside ultrasound. You'll treat the pneumothorax by needle decompression and the insertion of a chest tube. Cardiac tamponade occurs when fluid or blood fills the pericardium surrounding the heart. The fluid constricts the heart and prevents the ventricles from filling properly. Like pneumothoraces, this decreased filling is called preload, leading to a decrease in cardiac output. Causes of tamponade include penetrating trauma to the chest, such as a stab wound or gunshot wound, or may be caused by inflammation, among other things. You can visualize cardiac tamponade by using a bedside ultrasound, and if found, a pericardiocentesis or thoracotomy is needed to remove the fluid. Toxins, or an overdose of certain medications or illicit drugs, can lead to cardiac arrest. Information of what was found at the scene by EMS upon arrival is important because it can lead to the potential intoxicant. EKGs are also important to obtain given that some of these drugs can cause cardiac arrest by augmenting cardiac intervals. In addition to supportive care, a reversal agent or antidote may be administered if you have a strong suspicion for a particular toxin. A pulmonary embolism can lead to cardiac arrest, especially if they are massive. Large PEs obstruct right ventricular output, leading to decreased cardiac output and arrest. History is important if it can be obtained from a family or friend, because prior to arrest, the patient may have had signs and symptoms of shortness of breath, chest pain, and decreased oxygen levels. They may even have presented with a cough. If an EKG is obtained prior to the arrest, it will most commonly show signs of sinus tachycardia. Treatment is usually embolectomy, fibrinolytic therapies, and anticoagulant therapy. A coronary thrombosis is a blockage within the coronary arteries, leading to a myocardial infarction or ischemia. The occlusion of the coronary artery prevents blood flow to the heart, and as a result, the heart muscle dies. Cardiac arrest can occur depending on the location and the extent of the blockage and ischemia. History is also important if it can be obtained, most likely from a friend or family, because the patient may have complained of severe substernal chest pain before losing consciousness. If an EKG can be obtained, ST elevations may be present. In the acute setting, fibrinolytic therapy can be considered, but the definitive treatment includes angioplasty and stent placement, or CABG.
So, short recap of the video. There's not a whole lot here that we can really do that we don't already do with our standard arrest. Hypoxia. We are ventilating these patients. We got advanced airway in place and we're delivering oxygen. Hypothermia. We're going to work these patients until they're warm and dead. Often, if we have a hypothermic patient, a submersion or whatever, we're transporting these patients. Hypovolemia. Talked about my soapbox. We give a lot of fluids. So if they are hypovolemic, we're not ever guilty of not giving them enough fluid, I can tell you that. Hypoglycemia, we do a glucose check a lot of times. Hey, let's get a sugar. Now, hyperkalemia, this is something that we do need to be looking out for. Could this potentially be a bicarb responsive acidosis, like a DKA or tricyclic antidepressant overdose, aspirin overdose, potentially cocaine or diphenhydramine overdose? So in this case, we do want to give sodium bicarb. Now, if they have hyperkalemia, like they're a renal patient, we also need to consider potentially, sodium bicarb. Tamponade, cardiac tamponade. We can't treat this in the field. We're not going to treat this in the field. The only thing we can do here is recognize that potentially they may have it. We need to get them transported to get this treated. Now, this could be a traumatic arrest. We're running a traumatic arrest protocol. This can also be a medical cause. A tamponade is not uncommon for patients, cancer patients undergoing chemotherapy. They may have quite a bit of fluid in that cardiac sac. I want to say up to 500 milliliters, if I recall correctly, is not necessarily that uncommon for medical-related tamponade. And that's something that's going to have to be transported to get that cause reversed. Thrombosis, we just need to recognize that they potentially have a PE. There's not anything we can do in the field. They have a coronary thrombosis, a heart attack, or whatever. Not anything we can do in the field other than getting them to a place where they can treat that. And attention pneumothorax. I mean, we're listening to lung sounds after we get that airway in place. If we got lung sounds on both sides, we know they don't have attention pneumothorax. Now, if we don't hear lung sounds on one side and we have that eye gel placed, then, hey, why aren't they moving air here? We need to figure that out. Do we need to decompress them? Now, if we do an intubation, it's like, did we main stem intubate them? So do we got that tube going too far down one side or the other? And that's where we really have to do our assessment. Hey, I saw the tube go through the cord. I stopped past the cords. We look at the size of the tube. We see where it's at the teeth. And that's going to help us determine, do we need to decompress? And then opiate overdose. This is something else that we can treat, and we really have to look at our opiate-specific remedies. Opiates are a common one that causes respiratory depression, and ultimately it's going to lead to arrest. So Narcan would be an antidote for that. All right, we went through our steps. We rocked our code. We got ROSC. Great job. So what we're going to see in ROSC is we're going to have a rapid, sustained rise in the end-tidal CO2. So that's why we don't necessarily check post-shocks, for ROSC, because it's going to take a while for that organized rhythm to start really moving blood and for us to be seeing the effects. So we need to continue with that assist of providing compressions. But what we will see with ROSC is all of a sudden their body is perfusing, it's creating byproducts of metabolism. So we're going to see a rapid, sustained rise in end-tidal CO2. Patient may move, they may wake up a little bit. We may need to sedate them. So if we do have that rescue pod on place, we need to remove it because that is meant for compressions and when we're doing compressions only. We do not want an impedance threshold device when our patient may be breathing on their own. That's not going to be very comfortable for them. So obviously, for all our patients, and especially our ROS patients, we're going to be having vital signs. We want them on a ECG. We want to monitor their SpO2 and their end-tidal CO2. And this is saying assessed every 5 minutes. We're going to support their ABCs. We're going to target for normal oxygenation. We don't want to over hyperoxygenate these patients because that can lead to some problems in their post-arrest care. The goal of vitals is just to get them to normal. We don't want super high end-tidal. We don't want low end-tidal. But we're not going to really try to overcorrect these things. We're going to correct it if it's low. So if their SpO2 is low, hey, let's give them oxygen. If their blood pressure is low, hey, we need to assist their blood pressure and we're going to give them some dopamine. We want to titrate our SpO2 to about 94%. We need to obtain a 12 lead as soon as possible and transport these patients to a STEMI center if they're stable enough, if we feel like we can get them to that STEMI center, that cath, to get treated. Now, obviously, this is something that you're going to have to bypass Woodstock Hospital unless we're on the outskirts of our district. So once we get ROSC, we get that 12 lead done, I would be on the horn with Woodstock, be like, hey, we got ROSC, here are our vitals, this patient's having a STEMI, you want us coming to you, you want us going to the cath center. That's something I would do personally, but I know in past practice, a lot of times our ROS patients, we take them to Woodstock, they stabilize them, and then they get them out. Just something to consider. I'm not even suggesting that you guys should be doing that. It's never the wrong answer to go to the closest facility. We checked our sugar during the code, hopefully, but we're going to check their sugar again, make sure that that's good. And again, BP support. This is a high priority that they do not become hypotensive, so we're going to be giving dopamine. So we do need an IV for our dopamine. I don't think it would be successful giving it through the IO, so we need to establish an IV. And our dopamine, we're going to start at 5 micrograms per kilogram. So the way that we dose that is take their weight in pounds. So if they're 180 pounds, we drop off to 0, minus 2 from 18 to 16, and that's our 5 microgram per kilogram dose, 16 drops per minute. If that's not effective, we're going to bring that up to the alpha dose, 10 mics, so 32 drops. For peds, same thing, but check the dopamine chart in the back of the protocol. Get your specific trip rates for that. All right, this is the last portion of the cardiac arrest protocol, and it's targeted temperature management after ROSC. Now, I scanned the protocol. I don't see anything where it tells us what the indications and the contraindications are for targeted temperature management. And I'm going to go out on a limb here and say that this is not something that we've really been trained on, or that we necessarily have, the ability to do effectively. So up until the point where the system comes out and tells us, hey, this is what they want us doing, I wouldn't necessarily get too wrapped up in this targeted temperature management, because I know there's a lot of contraindications for it, and it's not spelled out anywhere in the protocol as of today, January 2021, on their website. So termination of resuscitation. The patient is normothermic and they remain in persistent monitored asystole for greater than 30 minutes monitored. Again, monitored. And if end tidal remains less than 10 for 20 minutes and no reversible causes of arrest are identified, contact medical control for approval of termination of resuscitation. We can get on the horn with the hospital at any time, tell them what's going on, and they could tell us to terminate or not terminate. So whenever in doubt, get on the horn, talk to the hospital, tell them what's going on, and they're going to give us guidance on what they want us to do. They want us to continue working, if they want us to terminate, or if they want us to transport. All right, that is it for this protocol. Stay tuned. We're going to have a short section on the COVID-19 specific guidelines. All right, guys, so looking at our cardiac arrest protocol here, there's not a whole lot of changes when it comes to COVID-19 specific alterations. The big one is that we need to be donning the appropriate PPE. So we are going to be gowns and N95s, which we're wearing for every call right now, and also our safety glasses. So keep that in mind. Also, if we have the ability, we want to intubate these patients over inserting an I-gel, because we can better minimize droplet precaution through the ET tube as opposed to the I-gel. And then finally, we want to place a bag over the patient's head, over the airway, to isolate those droplets to that specific area. So we have bags in the green bag to place over the patient's head while we're providing ventilation through our ET tubes. Other than that, the biggest change here for our COVID-19 specific protocols is, instead of 30 minutes of monitored asystole, they want us to continue our efforts for 10 minutes of resuscitation. And if they do not respond to that, we need to get on the horn with online medical control and tell them what's going on. And they're going to tell us if they want us to terminate or not. Other than that, our COVID-19 protocols for arrest are the same, exactly the same as they are for our standard protocol. And that's it. Thank you guys for listening.